Hi, and welcome back to my channel, Cypress Wellness Collective. In today's talk, we're going to talk about phase 3 of FBT, family-based treatment. This is the final phase in FBT, and so let's dive into it. So the goals for family-based treatment, phase 3, are focused on a return to health. So the goals for family-based treatment, phase 3, are focused on a return to healthy living. We've already tackled medical complications or malnutrition. We've already tackled a return to healthy behaviors with food and body. So we're no longer engaging in eating disorder behaviors. And in phase 2, we already transitioned to increased autonomy around food and recovery in general. So these are prerequisites for phase 3, where we're no longer talking about eating disorder behaviors so much because that's going well, and we're definitely out of the woods when it comes to medical concerns or any kind of malnutrition. So we can assume that your teen's brain is online, it's nourished, and we can have a really clear assessment around what are some of the other confounding variables here to psychological health and physical health. And that's really what we're going to be focusing on in phase 3. So we're going to tackle adolescent development issues like creating value-centered life and a balanced life. We are going to address body image concerns, and we're going to revise the parent-child relationship in accordance with remission of the eating disorder, right? So families really took over a lot of control and had to be really present in their teen's life. And for younger teens, this may not have been a huge change, but for older teens, it was a pretty significant change. So we want to look at developmental issues throughout the trajectory of a teen's recovery, and we want to revise the parent-child relationship so that we respect their adolescent development and independence and address any of the relational dynamics that were impacted by family-based treatment. And then lastly, we address any maintaining factors. Now, these are anything that, if left unaddressed, could lead to relapse down the road. So this includes co-occurring mental health conditions. This includes issues around body image or self-esteem or identity. This includes family dynamics, family coping patterns, or diet culture in the home. It could be so many different things depending on the client and the family, but it's important that we identify what those maintaining factors are for your loved one's recovery and that those are the goals of phase 3. Developmental issues are only addressed once your teen has resumed age-appropriate level of independence and no longer exhibits eating disorder behaviors. So if those are still going on, then we may not be ready for phase 3. Now, there are times where developmental issues need to be addressed in tandem with some of the ongoing family-based treatment, phase 1 or phase 2 issues. And this is where every case is nuanced, every case it depends. And so you really want to work closely with your treatment team and know your family to discern what kind of developmental issues are needing to be addressed. So feel free to think of this in a non-linear fashion. But in general, we want to see that eating disorder behaviors are no longer being engaged in, and we want to see that your teen is generally doing well with independence around eating and just body-based things. Every person's recovery is unique, and these developmental issues are going to be highly variable. Some examples might be reintroducing exercise, which can also happen in phase 2, decreased health monitoring, also may begin in phase 2, but it happens much more here. And then addressing body image concerns and addressing those co-occurring mental health conditions. We're going to talk about these in a little bit more detail. Reintroduction of exercise. This should start slowly, same as it did in phase 2 with food autonomy. We're going to gradually introduce exercise or healthy movement and then evaluate, how did it go? Were there ways where the eating disorder showed up? How did you cope with it when it did show up? Are you ready for increased movement? Or do we want to back off a little bit and just stay in this phase? So to start, you're going to choose one form of exercise and a type of exercise that's joyful, it's recreational, it wasn't necessarily a way the eating disorder may have taken advantage, and ideally it's a social activity. So first figure out what you're going to do, and then make sure that it's approved by your physician, and make sure that it's time limited. So if your team is an athlete and they want to get back to their sport, then let's start with just a part of their practice, right? And check in first. How did it go? How did they feel in their body? Were there any urges to engage in eating disorder behaviors? What kind of thoughts did they experience? How did they cope with it? Are they honest with you about it? Are they being proactive around their recovery? Do you get a sense of where their motivation lies, their insight, their judgment? It should be a comprehensive evaluation to make sure that they're supported. And then from there, you continue to increase forms of exercise in terms of intensity and time and the variety of activities that they're able to engage in. And then you just adjust in the same way we did in phase 2, offering more, offering less, just depending on where they're at and really what they're needing. The goal of exercise should be joyful, flexible, and embodied movement. And so joyful kind of goes without saying. If they're having, guilt if they're not exercising, if they're experiencing a lot of compensatory thoughts around exercise, like if the intention around exercise is disordered and not to be able to move in their body or to experience to movement or joyful activities like hiking or roller skating or something that they like doing, then let's reevaluate that. It should be flexible, so we want to challenge any kind of rigidity or rules around movement, and it should be embodied, so not in their head, right? Not thinking of, I need to be exercising this much today because I ate all of this food. So no compensatory mindsets, but importantly, to be able to tune into how the body feels. Are they able to listen to their body's cues for when they need to rest? Or maybe when they want to move more? Or if there's an injury, are they able to nourish their injury back to health before moving? So practicing of attunement to their body. Do they have the capacity to listen to their body and give it what it needs when it comes to movement? I like to suggest the compulsive exercise test if your teen was someone who engaged in compulsive exercise. It's a great tool to assess readiness for increased movement, and it's linked here, so check it out. And then decreased health monitoring. So if your teen is managing meal autonomy well and return to movement well, then the next goal is to decrease health monitoring. And that includes things like weighing or medical visits or psychiatric visits or nutrition visits, doing vital signs, doing lab work, like all of the things we had in place to make sure that they were meeting their markers in recovery. We want to start moving them away from that, and it should be a gradual reduction over time. So starting from seeing your clinicians to every 2 weeks, to every month, to every 6 months, to once a year, to no longer needing them at all. Weight is such a strong focus in the earlier phase of recovery because it's such an important indicator of health and whether we're meeting our behavioral goals in those earlier days. It can be very scary to move away from monitoring weight because we lose some of our transparency in how things are going. But at a certain point in the recovery process, we really want weight to take a back seat. We don't want to focus on it so much, because by focusing on weight, we inherently cause your teen to focus on weight. And part of their eating disorder was to focus on weight. And so at a certain point, we really want weight to not take up a lot of mental space, right? We want them to be able to develop a sense of their recovery outside of weight. And we definitely want them to develop a sense of identity outside of weight, and any other physical markers, right, of health or themselves as people. And so we move to a more robust psychological picture of your child and of how we measure their recovery. So psychological health includes, but of course is not limited to, what their relationship with food and body looks like, what their relationship to self-esteem looks like, or self-worth. How do they feel about themselves? A sense of identity and relational functioning, like how are they relating at home, or how are they relating with peers or at school, and then co-occurring mental health conditions like anxiety, depression, or trauma, and then of course family functioning and anything else that might resonate for your teen. This phase, we're also going to address any co-occurring conditions, and co-occurring conditions often refers to a psychological condition or a medical condition that perhaps was kind of covered by the eating disorder. And now that we've addressed a lot of the eating disorder issues, we can see more clearly that there's some other thing that also needs attention. Most commonly, this tends to be another psychological condition like anxiety or complex trauma or depression or obsessive compulsive disorder. And if these things come up, typically individual therapy is recommended at this point. And individual therapy is a very different type of psychotherapy, and there are different forms of psychotherapy in that umbrella term, individual therapy. So it could be a cognitive behavioral approach, it could be a psychodynamic approach, it could be something totally different, but this is where it's really important to work with your teen and with your treatment team to really understand what else is going on here and how can we make the best referral or recommendation for the next step in recovery. Another thing to consider would be psychiatric medication. So early in the recovery process, especially if someone is underweight, but not always, but definitely when they're engaging in eating disorder behaviors, most likely we do see signs of malnutrition. And because we know that malnutrition can lead to psychological symptoms that mirror anxiety disorders, depressive disorders, and many other types of psychological issues, we often aren't recommending a psychiatric assessment or medication intervention at that phase, because a lot of the times those psychological symptoms will resolve just through nourishment. And sometimes they don't resolve, but they decrease significantly in terms of the symptoms someone experiences. Now, there are times when you might want to consider psychiatric medication much earlier in treatment, and this is definitely true if someone is really struggling to make progress in family-based treatment and you've been trying it for maybe several weeks already, or if someone is pretty medically fragile and needs a much quicker path to recovery. It's something that could be considered, and there's different types of medication intervention. So we may be thinking of a more short-acting anxiety medication rather than a mood stabilizer or something that's more long-term. But regardless, at this phase in the recovery process, when someone is nourished, we expect their brain to be online. We can see more clearly what are the other psychological symptoms that have not resolved and what are some other interventions we can provide some support with. And then lastly, think about traditional family therapy. FBT is a really hard treatment for families for so many different reasons, and sometimes it can illuminate some other family dynamic or family relationship issue that would be worth continuing to address, especially when we think about maintaining factors. And if there are things that came to light through FBT that we don't address that could potentially not cause, but contribute to a relapse down the road, it's worth considering. Let's continue family therapy, but an important switch from FBT to family therapy. FBT is a directive, intentional, and kind of very specific treatment approach that's focused on the eating disorder as the thing that needs to be treated. And so not every person in the family therapy space is treated equal, right? A lot of eyes are on the person with the eating disorder, and there's a specific focus around what kind of behavior patterns need to be changed. The difference in traditional family therapy models is the family is, as a whole, is considered the client. And so not just one person is focused on, it's really focused on the whole family dynamic and the relational issues. And so it's a very different approach and worth considering if there are some other things that would be worth. And body image issues. So early in treatment, we know that body image issues in the case of anorexia and bulimia and other specified eating disorders are pervasive. They're a significant part of someone's experience in their eating disorder and often a barrier in recovery. It's delicately avoided in the early phases of recovery for good reason. We know that clients who are in that pre-contemplative stage of change, meaning they either don't see that there's a problem or they see that there's a problem, but they don't want to get better yet, which is very common in eating disorder recovery. If they're in that pre-contemplative state of change, then they're overly aligned with their eating disorder. And this often means that they're not in a healthy enough mindset where they're able to process body image issues in a productive manner. And in fact, processing body image issues when they're in that mental space can often reinforce the eating disorder's drive for thinness or to thwart treatment efforts. And so we purposefully don't talk about body image issues when someone is really struggling with it but needs to gain weight or is just struggling to get on board with the need for that recovery. It needs to happen. Now, that doesn't mean that we don't talk about body image issues at all, or that we don't talk about the fact that someone needs to gain weight. We're definitely going to communicate that someone needs to gain weight and the reasons why, and we'll validate how hard that is from a body image standpoint. So it's not to say that we don't talk about it, but the key difference here is that we're not going to process it deeply in a therapeutic manner and expect that someone is going to be able to have a different feeling about it in the earlier phase. It isn't until we reach certain markers around externalizing the eating disorder and motivation where we can begin to process body image in a healthy way. And research often shows that this is one of the final issues to be resolved in eating disorder recovery. So it happens in phase 3 and beyond. And then once we've addressed all of these developmental issues and tackled those maintaining factors, we're going to focus on relapse prevention. Relapse rates are high in eating disorder recovery, which means that relapse prevention plans are essential. And a relapse prevention plan is exactly what it sounds. It's a plan that's put in place to try to prevent relapse from happening down the road. Key ingredients to a relapse prevention plan will include identifying challenges or triggers that, if they were to happen down the road, it may bring up stress or it may bring up eating disorder thoughts or urges or behaviors. And we want to identify cope ahead plans so that the person or the family is equipped to navigate those transitions or stressors when they do come up. And so they'll have a comprehensive kind of coping strategy to help them when these things happen in their life so that they can stay steady in recovery, or even if they don't stay steady in recovery, that they have a plan to get back on track. And so we identify green, yellow, and red signs in recovery, and these are as exactly what it sounds like. So a green sign would include, what are all of the signs that things in my recovery are going well? I'm having flexibility with food. I'm exercising in a way that brings me joy, and I'm not creating rules around it. I'm not isolating. I'm going out with my friends. I'm connecting with my family each week, and I'm going to my uh, therapy appointments or whatever it looks like. And then we identify those yellow signs. And these are signs that things are stressful and they're not going as well as I wish they would. And yet I'm not in a relapse. So I may be in a slip. I'm slipping with something. So maybe I've started to revert to safe foods and I'm no longer challenging myself with a lot of food flexibility or variety. Or maybe I'm still going to therapy, but I'm not being as open and honest as I was before. Or maybe you've started to withdraw from your friends. And then we identify those red signs in recovery. And this might be weight loss. It might be counting calories again. It might be shutting down completely and no longer talking to family around what you're struggling with. It could be all sorts of things. So it's important that you and your teen identify what are the green, yellow, and red signs for your teen's recovery, and then what are the safeguards that you're going to have in place for those yellow and red zones. Now, this looks like, this is what I'm going to do to help myself if I'm noticing these things go on. This is what my family is going to do if they're noticing these things going on. This is what our communication around those issues is going to look like. This is what the treatment plan is going to suggest, or these are the expectations that we're going to have around checking in or going back to phase 2 or even phase 1 of FBT. So it really depends on what those green, yellow, and red signs look like to know what kind of safeguards are going to be recommended. But importantly, you should have some kind of plan in place that you can refer back to and check in with it regularly. So when you're first making a relapse prevention plan, I recommend that the family and teen have a meeting around it at least once a month. And as you're 6 months out, maybe you're only checking quarterly, and then maybe you're only checking every 6 months or every year. And then you're no longer needing it. But importantly, it's there because you've done so much work to get to this point. I always recommend that parents be inwardly cautious, but outwardly optimistic. It's natural to feel scared and overwhelmed when we move to this phase in the recovery process because you lose transparency, right? We're pulling away medical monitoring. We're giving a lot more freedom with food and exercise, and we're trusting that your teen is ready to handle these things. And it can be really scary and it can be very overwhelming. And a lack of transparency often increases anxiety. However, if we lead with that anxiety or we lead with fear, then your teen will often pick up on this and they may feel untrusted, or worse, they may doubt their own ability to handle it. And we want them to trust themselves, right? We want them to figure out how to be in recovery and be in their life and navigate all the triggers and stressors that there are in the world and choose recovery again and again and again. So it's not without difficulty. And as parents, it's so important that you have some risk tolerance to be able to support them through that process. So be cautious, but be optimistic. You're going to have guardrails in place, right, to know when to step in, when do they need your support. And you want to be approachable. Right? And so you don't want to be reactive when they struggle. You want to support them in reaching out to you, being honest about those struggles. You want to be able to tolerate that risk and continue to support them in developing their own voice in recovery and their own strength and courage as they continue to move forward. Remember that recovery is possible. This is a challenging road, but it is so worth it, and you can do this.